Okay. Welcome to another episode of Podding with PT. I'm Tyler.
And I'm Patrick.
And today we're joined by Dr. Kyle Richmond, practicing out of Illinois. So, Kyle, if you can just give a little presentation. Thank you for hopping on the show also.
Absolutely. Thanks for having me. All
Yeah.
right. So, little background on who I am. Grew up interested in chiropractic, went to one for basically mostly sports injuries. My biggest thing is I separated my shoulder playing soccer, and it was a chiropractor who still, kind of practicing that PT realm who actually helped me avoid surgery. I'm like, okay, this is amazing. Ankle sprains, you name it. That was the guy I went to. Fast forward, God, almost 10 years. I knew I wanted to be a chiropractor when I was in like high school. So by the time I finally got to graduate school, kind of making the decision. I went to school locally around Chicagoland area. So I was like, okay, I need to venture out and go somewhere else. So I picked graduate school out in Davenport, Iowa. It was Palmer Chiropractic. Knew nothing of the school. Turns out heavily philosophy based, a little bit different than what I anticipated. But throughout school, I was able to find things such as MDT, FRC. FRC changed my entire view on things. Like I'm sitting in school like second trimester going, this might not be for me. Like I might go to PT school because this stuff makes a lot more sense. Like we're just talking only manipulation, like 1800s, like stuff, right? I'm like, this is not what I anticipated because I just didn't know, right? I got adjusted, but it wasn't like I need to get adjusted. Felt good. So basically, during when COVID happened, I was in like, God, my third trimester of school, and FRC started going online. And I'm like, oh, I can take one of these courses. I've seen all this stuff. This is awesome. Went through the whole FRC seminar, fell in love with it, and kind of found a way how I can implement it within practice. Because I come from more of an exercise-based thing. Like when I treat someone, usually they come to me because pain is a big deal. Let's get rid of pain. And then what's the next step? Because again, I don't want to say pain's easy to get rid of, but for some people, we can get rid of it pretty fast. And now what do we do after that? And with my background, like I can go into training. I did CrossFit for almost 10 years, personal training, you name it, sports. So I had a background of exercise. And I'm like, how do I piece all this together for patients from 13 years old to I treat my 93-year-old grandfather with FRC-based principles. Like he's doing hip cars, he's doing obviously capsule-based stuff, but that I guess that's kind of a background of me. I don't know what else you guys want to know, but I'll let you guys take it from here. I can talk all day on that.
Yeah. So, talk to us about because that's really interesting. Because I was a little bit later into the FRC. I would guess a scope of how to treat. But if you can talk a bit about what your interpretation of FRC is, and then the other stuff. I think you said MDT also.
Yes. So
okay.
I don't know. You guys are familiar with MDT. You guys, I know you guys touch on in PT school. For me, being chiropractor was like, oh, this is great. I can teach someone how to essentially kind of treat themselves or have a progression system that isn't just adjust everybody. Like, okay, there's a system here. I fell in love with that. And then with FRC, my biggest thing is it gives me an assessment, right? Because from any age group, any athlete, I have an assessment. Okay, I'm looking at a hip joint. Do they have rotation? Is there pain? Is there a pinch? Like being in a chiropractic school, you didn't learn any of that. They had a very outdated, extremity assessment. It was just like, okay, is the range of motion good? All right, cool. It's there, I guess. Now what, right? And you're kind of just told, do whatever you want. Well, now I have a system in place, right? I can check their passive motion, their active motion, the pinch points, the lack of control, whatever it is, and it gives me this framework. So I predominantly treat with it. Outside of things on day one, I'll use MDT for more of like our radiculopathies, any pain that's traveling, like I'll assess global movement. But basically on day two, I'm already trying to go into whether it's segmentation for spinal stuff, whether it's capsule-based inputs, if they have knee pain, sure, I can extend some people. It works. I won't lie, it does work, but then I'm already going into, do they have rotation in the knee? Do they have active range of motion? Like all these different things. But the whole system gave me at least a starting point. Because when I'm going through chiropractic school, I'm like, I know how to adjust. We do a ton of that. I guess I'm good at it. But what do I do with everybody else after they don't? I mean, most people come to me and they go, you're a chiropractor? Like they'll find that out on like day 3. They don't get it. And they're like, oh, that's awesome. Or all people come to me and like, listen, I know you guys don't adjust everybody. And I kind of like that. Like, how do you help me without adjusting? So it's definitely different. I definitely shy away from introducing myself as a chiropractor all the time. There's a bad stigma. And I tell them I treat essentially like a PT. And again, I didn't go to PT school, but in the sense of like exercise is my big thing, right? Get somebody moving, teach them what they got to do. And FRC lays a great groundwork for that. Like there's a whole progression system. I just went to the internal strength model and they taught us just how to program from, your higher level athletes where we put everything in, but then from a base level of, okay, I start with cars, I do capsule work and cars again, I go rotational, and they gave me that input. So now when I'm actually teaching somebody in the clinic, like in a half-hour session, we kind of go through that checklist.
Gotcha. You said NDT or
MDT, so McKenzie method.
Okay. Yeah,
You guys
I was
touched-
like, what, yeah, I wasn't sure what you were talking about, but the McKenzie method,
Yeah, that's what it is. And again, being in chiropractic school, I was like, oh, this is awesome. There's exercise. There's some movement in this. It's not just, a passive modality. That's all we learned, unfortunately.
Yeah. How long have you been treating as a chiropractor?
So I graduated in October of 21, so a little over a year now. And again, if I didn't have that FRC background, if you put a patient in front of me, it's more like, am I just feeling for tissue? Like I really didn't know until, but I mean, I figured it out obviously during school, but then when I'm in my clinicals, you're not really using that stuff. You kind of like shied away from. So it was always, I'd be working with my buddies. Like we'd be, hey, let's go to the gym. Let's do this. Let's run through all this stuff. So I have an idea of where to start.
When did you start getting involved with FRC?
So that was my 4th trimester. There's 10 trimesters. COVID was 4 and kind of into 5. And I was like the only one in my school. Like, I mean, there's a couple thousand kids there, and like no one else wanted to touch this stuff. I'm like, oh, this is great. Like, it made sense to me. Again, there's just some sort of there's objective findings, right?
Yeah.
There really is a lack of this. Let's do this versus, I mean, I'd say most things in chiropractic tend to be subjective, right? Like, okay, I'm feeling this, but what does that mean? Like, I don't know if you've seen any Dre stuff like the soft tissue, like ADFR courses. Yeah, what are we feeling? Is it mechanical tightness, neurological tightness? Like, how do you deal with that? That was their big thing. Once you find out that it's a neurological tightness you're dealing with, well, that changes my entire way I'm treating that. Like, I don't do a lot of scraping, taping, icing, heating. I mean, we're a cash-based model too, so I don't have to go through insurance, so I'm not required to do X, Y, and Z, which helps me a lot. I don't know what you guys do, but that's been huge because I'm allowed to do pretty much anything, right? Which is great.
Good, Pat.
I just want to say FRC is functional range conditioning. We just kind of went right into it.
Yes.
So for those that are not familiar, functional range conditioning.
Yeah, I agree wholeheartedly with the system, because when I got out of school, I had a lot of information, and I'm assuming that chiropractic school is the same as PT school in the sense that you kind of you learn just a whole lot. You learn a little about a whole lot.
Yes.
So it's now when you get a patient, you have to take in 3, 4, however many years of schooling and all of their history. And that's years and years of trauma, injuries, whatever it may be. And now you have to try to like connect with them. It is a really hard way, especially I didn't have FRC. Well, I kind of knew about it before I did like an in-service on it. So I knew what it was about, but I didn't go to the actual seminar by that point. So I had a lot of information, but going to the seminar, we went in person. I think, was it springtime? No, that was like Thanksgiving. It was the first one that we went to. I think it was like a week before Thanksgiving, and it was life-changing to the sense where it just made sense.
Right.
Where, yeah, I've learned different techniques. So certain techniques only work for a certain population. But what I like about FRC and their functional range systems is I just got to take you as a human being, and can you do what a human being is supposed to do? It doesn't matter if you're 90, it doesn't matter if you're 4. Eventually you have to have some level of movement or some level of body awareness and control. And it's like there's no boxes they leave unchecked. They make sure that they tell you, hey, this is exactly why we're doing this. This is exactly the progression. And there's just science at that point.
Right. Well, you said like you leave school and you're like, hey, I know all these orthopedic tests. I know all these, like, I get knee pain, Lockman's, varus valgus, blah, blah. Well, what does that mean? I mean, if I have a clear ACL tear, okay, awesome. Then I'm sending you on the way. Like, you need something else. I mean, could we rehab it? Whatever. Yeah. But yeah, you have all this information. Like, how do I channel this to an assessment? And I don't know if you guys have taken like FRA. Essentially, it's the active and passive. So, all right, so Patrick, so FRA is functional range assessment. So basically, let's say I took a hip joint. I take it through internal rotation. Okay, that's their passive range of motion. Then I have them take it through. That's their active. That array will tell me, hey, do we need active inputs or passive inputs? Like, do I need to expand passive range of motion or active range of motion? I don't know, Tyler, have you taken that one yet?
I've watched some of the videos and watching the webinars. They kind of go over that, but then we also just talked about because I have a student right now and he's a good friend of mine. But I haven't really forced him, but I showed him FRC and he's just been in love with it ever since because for him, what it helps with is it's not specific. You have to do this, but it's let me take your overall movement. What can you do? What can you not do? What part of that do we need to make better? And then just make it better. Just make it look nicer.
100%,
So
100%,
if you have, you have the passive range, then it comes down to two questions. So do you have the passive range to even get there? Then once you have it, do you have the active range to control it? So if you don't have one of the two, I can just boil it down to those two and it gives me pretty much my treatment plan.
Right. Yeah, you have an idea. Like, again, go ahead, Patrick.
Yeah, I was gonna say, taking FRC, it wasn't as life changing as Tyler describes for me because since we're roommates, we talk about our treatment styles or things that we're seeing throughout, the day. And so when he took the TPI course and the way that TPI breaks down every single movement, and then also with my mentorship at work, it was like, all right, let's just break it down to the base movement. Can you complete the base movement before we go anywhere else? Yes. That's what I'm already thinking. Yes. And then going to FRC is like, now they have a system and a way, all right, you acknowledge the base movements, but where do you go from there? How do you train them in different positions and specific movements? So I was like, wow, it just makes sense to all right, now that you can do this, how do you progress? Right. And now taking that and making it sports specific or activity specific, it was just really cool. So that's what I bring into my type of treatment plans. I was like, first thing when you come in, what do you want to do? Yes, 100%. And from there, I was like, all right, this is where we're going to build, because at the end of the day, it doesn't matter what my goals are for you if those goals don't align with what you want to do. Yeah, patient-centered care, right? What they want matters. I can find things, but it's got to be what you want. They got to be bought in. And I think I get great buy-in with people because it's easy to give them a home-based exercise plan of even just something simple like, hey, you're just going to do wrist cars at home, and they get that. It's scalable too. I'll take it from a 13-year-old to a 93-year-old. There's something in that system that's going to put them to the right spot they need to be, and it's fairly simple, whether it's capsule-based work or something just small. And even for an athlete, right? I don't even know what sport you play. I just need to look at, does your shoulder do what a shoulder needs to do? Yeah, there's some exceptions, right? Baseball player probably needs excessive amounts of external rotation if they're a pitcher, but at least you have a baseline for an athlete. I don't need to know how you throw. I just need to know that moves well, right? I don't have to go into your biomechanics of how you run. Does your ankle move well? Does your hip move well? Does your knee move well? Okay, that's kind of my job. I'm going to give you to the specialist then who deals with that.
Yeah, I've really liked it because for me, I've taken so many courses and I've liked a little bit of what this one did and a little bit of what one of the other ones did. One thing I didn't like about a lot of other courses was, oh, here's level 2 or here's level 1, but you probably really need to take level 2 in order to really understand level 1. Whereas with this system, it's just here's the information. Now I can give it to you in different ways. Like, do you want to take a group training class that's Kinstretch? Do you want to go with more the strength and conditioning? You could also do that for programming. And then they have the assessment, but everything stays the same. Whereas does this joint do what it's supposed to do? If it does, okay, how can we make it better if it's limited? And if it can't do it, let's make it do it. So it made it really nice to have a simplified way of looking at each person and going from head to toe. So I want to kind of know a little bit more about your experience with the FRA. But in the assessment, essentially, I just look at the morning routine, which is every joint from toes up to fingers. So that way I have an idea, but also I give that as homework for everyone. So first, even no matter what they're coming in with, because guaranteed a lot of people have more than just one thing going on.
Oh yeah. All the time. All the time. They come in like, hey, by the way, do you guys treat ankles? Yeah, you've been here for 6 visits. Bring it up. Let's do it.
Yeah. So yeah, I'm curious to know how your assessment plan is or assessment process is.
Okay, so biggest thing for me on day one, I always rule out radiculopathies. I get a lot of people to have, because being chiros, they think, okay, spine related stuff. My neck hurts, goes down my arm. Okay, well, Could use some FRC stuff, yes, but that's where I tend to treat with a little MDT. Get rid of that stuff so pain's not, because pain can really muddy the waters for a lot of people. It definitely makes it hard to move and everything. So once I've kind of decreased pain, usually by visit 2, okay, now I'm starting a CARS assessment. So let's give the example of a shoulder. I look at the fundamental motion, internal, external rotation. So I passively do it. I bring them through the motion, then I have them actively do it. Because I'm looking at what's their passive range of motion and their active. It should be about a 1-to-1 or at least close to 80%. Okay, so let's say they have a ton of internal rotation passively. Then I have them do it and they're like, this is all I have. Well, I'm not going to give you sleeper stretch because we know passively that tissue has the ability to get there. We now have to get lift-offs, holds, and increase the ability to get there. So that's what it tells me on day 1. Like if I get someone who is just super flexible in their hip, well, I'm not going to put them in 90-90 to stretch anymore because they can get there no problem. They need more of the control. So your positional isometrics, your pails rails, lift-offs, hovers, all those things. So that already at least gives me, I know the 2 categories I'm in. Like I always educate people on flexibility and mobility. Flexibility, how far I can move you passively. Mobility, how far you can move yourself actively. That already puts them in these categories of kind of treatment, right? And then, okay, do I need more pails rails? Do I need more stretching? I mean, most people, you blow their mind if you tell them they got to hold a stretch for about 2 minutes. So like, that's the eternity, but for the right population, it works. Because I get a lot of people like who do yoga, right? They don't need to stretch anymore. They need control. Like they can't even lift their leg off the ground. I think it's hilarious having people, I will do this assessment, like get a 90-90, go ahead, can you pick up your back foot off the ground and just stay at it like it's not going anywhere. But FRA at least tells me that. It tells me where I need to start. You have CARS, and you also have more of like your objective findings. Is it passive or active?
So one thing, so then can you describe a bit of CARS? So talk to me about what CARS is, and then we'll kind of branch off from there for those that don't know.
Okay, so CARS stand for controlled articular rotation. I break it down to people in office as it's a slow joint circle, right? We're going to use this to kind of see where you can move. I let them start really just kind of not blocking them, not making a lot of corrections. I just want to see how aware are they of their surroundings. Like if they do a shoulder CAR and their whole body's going, okay, well, I'm going to make some corrections, but I look for pain, I look for pinch points, and I look for just overall ability to move. And you can start those passively. You can start them real gentle for just getting rid of, ankle. Like someone has a sprained ankle, right? Day 1, they're already starting to do slow, pain-free motion. Then you can train them. I get people, I load them up. I give them the weight in their hand, and they're actually doing weighted CARs. So they're super, again, the great thing with this system, it's scalable. You have principles you treat off of, but from someone who's an acute ankle sprain all the way to someone who's trying to be the best sprinter in the world, like there is a place for CARs on that. Like you said, you do the morning routine, super low intensity, and then I can have someone training CARs. Like I literally did that today. You're training CARs, which is, awesome because of the scalability aspect.
Yeah. So can you talk about like the pinch points? And because I thought that was extremely helpful for me when you start to talk about closing angle pain and pinch points. So if you can kind of speak on that and how you look at that.
Absolutely. So what a pinch point is, and this is how they describe it, is when you have an articulation where the bones or whatever's in there is hitting each other, causing that, again, that pinch. Well, we have to look at the fundamental motion of a joint. And most of these joints is rotational capacity to expand space. And for me, like I came from this CrossFit background of like, I'm going to bandage stretch the heck out of my ankle and my hip to get rid of this pinch. The pinch basically means we're running out of space in a joint and the bony articulations are kind of hitting or, creating less space in there. So that tells me my treatment. First off, we have to expand space in the joint. If you're pinching in hip flexion, I'm just driving you into more hip flexion. That's not going to get any better. We have to then back off and go through rotation. So that was a big, opener for me. Like I'm getting a lot of people with wrist pinching, ankle pinching, hips. Hips are always a big one, right? On the bottom of the squat, my hip pinches. People are just stretch your hip flexor. Well, once you find out it's actually at the joint level in terms of the capsule, well, that changes your entire treatment.
Yeah. That's huge because I know that one of the things that they said, I think it was in the FRA, but definitely they said it in one of the webinars, was if you find a pinching, check like you said, rotation. So the most fundamental motion of the joint, check rotation. Usually that's probably where it's causing the problems. But as a student or when you're a new grad, you think, okay, let me check flexion, let me check extension, let me check abduction, adduction. Now you have all these limitations. And yes, you see rotation is probably limited, but I don't think I knew as a student, okay, go to rotation first, and then the other ones will start to get better. And then once you open up some space with rotation, now you can go to those linear things like flexion, extension, abduction, or adduction. So I think that was a good way of even knowing, all right, if we go through this and your shoulder has a pinching or your hip has a pinching, I already know check rotation. It makes it that simple.
Yeah, because if they're getting inflection, they're just going to keep driving them with a banded stretch. And I was thinking in school, you're just taught orthopedic tests, right? You have all these orthopedic tests, and then like it means something anatomically, like there's a damaged structure, but that's not always the case. And we find out it's very unlikely. I can take anyone through Apley's scratch test and they go, well, yeah, this hurts. Well, the rotator cuff's not torn, because if I can change that in 30 minutes of treatment here and all of a sudden you're not having pain, well, there's probably not a tear in there.
Yeah.
Right? So at least that was the biggest thing with school, right? You're just taught all that. Oh, this is what I know. And I don't blame anyone for it.
Right?
Yep.
And so, especially at first, when I first treating, I was like, all right, you're just going to have to work through that pain.
Yeah.
It's going to get better. You just got to work through it. Now,
yeah.
Like, all right, stop. Like,
right. Let's not do that.
Right. Like, yeah. So it's, your body's telling you, we don't like this. So, and now I have to ask you more questions. All right, what type of this pain, what type of sensations are you feeling? Is it burning? Is it pinching? Like, we're not going to work through that. Like, let's take a step back. Let's create some more like workspace for your joints to move.
Exactly.
And now let's train a different way to get you to complete that task without the pinching.
Right. 100%. 100%.
Now is like, once you feel that, just stop.
Yeah.
That's your body telling you this is not going well.
Right. I don't know about you guys, but in school, like they address pain a ton. Like pain's extremely complex, and we kind of just like almost brushed it off in a lot of my classes. Like we'd be in extremities class, and we're not really talking about hip pain. Like it's just like, oh, if there's some pain, all right, just don't do that. Like, and that was it. Or just go ahead and put stim on it. And I was like, well, what does that do?
Yeah. So I really didn't know, but I think what's interesting, because we talked a lot about pain science, but I think just because you're like drinking from a fire hydrant when you're in school, that you understand it, or you hear it, but you don't really understand it, is how I took it. And even like patient-friendly language is one of the things that we learned, we emphasized a lot, but it didn't make any sense to me. So don't say things like be careful or things of that nature, because now people think that they're quote unquote fragile. But in terms of like the pinch points, I find it funny that they say you don't have that joint if it doesn't have the fundamental motion, which made me be able to explain it to people a lot easier. So if for example, I think I was talking to someone about doing RDLs, so single leg RDLs, and they said, is that great for like a hip exercise? And I said, well, first, do you have a hip to do the RDL with? And if you don't have the hip, it's like something else is probably compensating, because those muscles in the joints don't have enough workspace. So it's a good way for me to even explain to people, yes, it's like there's no good or bad exercise, but do you have the capacity to do it? Does your body have the prerequisites to perform that motion?
Yeah. Oh yeah. And I think FRC's done a great job at like being able to explain to patients, right? There's not a lot of fear mongering. You know, you can easily just like, I call them, hey, cars, like that doesn't sound like anything that's like detrimental to them, right? Okay, explain why we're avoiding this, what we have to do. There's a lot of like, it's objective based findings, and people really appreciate that versus saying like, oh, I think this is kind of stiff on you. And they go, well, what does that mean? You show them, hey, you don't have this motion. You need this motion to have a shoulder or to have a hip. And they really get on board quick, and they go, okay, that makes sense. And you can teach them these things a lot easier than just saying, all right, you have a bad shoulder. And they're like, yeah, I know.
I like the cars as an assessment as well, because one, like you said, it highlights to them. Most people, especially everyone knows like the toe yoga, where they have no idea how to move that joint, and they're like, is this even possible? And I know Pat laughs at that all the time.
They stare at their feet. They're like, how are you doing that?
I'm in the clinic, I take off my socks and shoes, I'm just like,
here you go. Yep. I love it.
But it's great level of education for me to sit there and say, hey, this is what this joint is supposed to do. Can you do it or can you not? If you don't want to do it, or you want to like negotiate with me on your exercises, that's okay. Like I personally don't care, but I'm showing you, hey, this is really important for the motion that the activity that you want to do. You should be able to control this in a safe environment. Like this is the least amount of stimulus. So now if you can't do it in this environment, how are you going to do it in a more chaotic environment? And so I think that's been a good way for me to get buy-in with people. And I know they use the example of dentists tell you to brush your teeth at least 1 to 2 times a day, and nobody has problems with that. But everyone complains when I tell them this is something that's daily. Like you don't need to, but if you want to keep or maintain joint health, probably should give it some motion.
Oh yeah, I give my patient that same example. I'm like, you don't notice the difference if you don't brush your teeth for that one time. But if you don't brush your teeth for an entire week, you're gonna notice that. Like,
yeah,
it's your joint, right? Oh, I don't notice that. And I've never had someone come to me after doing a car and be like, "Man, that feels worse." Everyone gets done like, "Oh, my shoulder really feels good." They're like,
yeah.
So, I mean, I've never had any complaints on it. People think,
yeah, and I like the idea of just like when I explain to patients, like if you don't use it, you lose it. So when I give cars, it's like we're taking your joint through its full range of motion. So at the end of the day, like you want to take each joint through its full range of motion. So in 5, 10, 15, or whenever you're 80, you want to be able to move your shoulder through its full range. So if you don't start now, it's like you will start to lose that motion.
and they don't realize it till it's gone, right? Like I see a lot of people, like, again, being a chiropractor, a lot of spine pain. People, their necks are like, this is as much as I can look up. You're like, well, you're 40 years old. What do you mean that's as much motion? Well, because they never have a reason ever to look up and do that or extend their spine backwards. Like you guys probably put people through segmentation. They have no awareness of their low back.
None.
Why they have back pain. I go, well, if you took your arm and just couldn't move it, would you think that would hurt after a while? Like, well, yeah. Well, same thing with your back.
And that's what I love being able to, because it is an assessment, but then it becomes homework for me. For one, as a student, you're like, well, shit, what are the 5 exercises I can get them to do right now that they're going to maintain? And is this right? Where now it doesn't matter to me what you have. I'm giving you the same exact exercise because at the end of the day, you're a human being. You have to do what human beings do. So, and the better you get at that, one, I think it's interesting because more so than anything, I think it's a conscious or an issue with focusing. Because I feel like people don't want to take the time to focus on different body parts because it's just not that important in our society. Whereas now you can, this is meditation. Because the other question I ask people is, do you like to meditate? And I find that those who hate meditating also are not as adherent to their exercises because this is just a moving meditation. If you don't like 10 to 12 minutes, and if you do this every day for the rest of your life, you're at least going to stay the same of what you are. You won't decline. So if I can tell you for 10 to 12 minutes, I can each day, if you sacrifice that out of your 24-hour day, you can stay exactly how you feel now. And you have a problem with that, I know that we're probably not going to be compatible to work together.
Oh, yeah. I mean, I get a lot of people because, again, their pain's gone. Like, okay, now what? I'm like, well, I really have to emphasize just because pain's gone doesn't mean things are like fixed, right? You still have a hip that doesn't move. And then they go, okay, well, how long do I have to do this for? I'm like, once a day for pretty much the rest of your life, you want to keep it, right? Or at least give it a few times a week. Because if you don't, I'm going to see you in the clinic in another year from now with the same problem because we never addressed that issue.
Yeah.
And now you have the objective findings saying you still don't have a hip. Well, if you have a hip and you move it every day, well, there's no reason you're ever going to lose it.
Not going to lose it. Law of specificity. And I like how they bring up things like law of specificity. So that's very easy. And I think it's cool to be able to now talk to patients and clients and get them on board with this type of education. So now it makes sense to them in their head. Okay, if I never move or use this range, why would I have it? So now they at least can think about that going forward. So I try to get it in a sense where I want my patients or clients to be smarter than the next PT that they ever see. So if they can at least know their body better, that's my end goal. I love to create like the connection and communication, but I want you to have a level of understanding of your own body that you don't need to come to me for another body part, but you want to, because now you're creating that level of understanding for yourself and that positive environment.
Oh yeah, the patient education, right? If they can explain back to me at the end of the visit, like what's going on, well, I won. They understand it. Like they'll come from our providers, like I had back pain and I don't really know why. I don't know what they did and I don't know how to fix it. Well, the whole thing is I need to teach you again how you can essentially treat yourself, right? Or at least have the autonomy to understand and keep this there. Because you'll come to me for a visit, your back pain's gone, but you need to understand what you're doing outside of the clinic for the other 23 and a half hours out of the day.
Yeah.
That's the big thing. Like you only see me for a half hour, sometimes 20 minutes. Like there's way more than, what you have to do, unfortunately. But if you get them on board, they get it.
Yeah.
And I think so taking them through cars and just being able to recognize pinch points, it just creates a level of body awareness that
Right.
they probably have never thought about.
Oh yeah. No.
And now when they're doing anything like walking their dogs or whatever, they're like, oh, this doesn't feel good. And so now they're able to recognize it, or if they not bring it to you, bring it to their next provider. So hopefully who listens to them.
Yes.
Like,
Yes.
another side of that, but like now you can like, all right, they know their body and they know what they're feeling. And for me, that's major, because it's like, you know your body the best. You live it every day. So
yeah, no, and that's the paradigm shift too now. Is like patients are coming to my office like, I'm like, you gotta be ready to move and do things. You're not just gonna lay on the table and it's spa day. Like, and that's, I think there's a difference. Like going to PT, people know like, all right, I gotta move here. Like this is something. People come chiropractic and like, all right, we're just gonna rub my neck. Like you haven't been on the table yet. I'm just assessing and you're moving. They're like kind of breaking a sweat in 20 minutes. But they leave feeling better, and that's the biggest thing. And then they know what they need to do.
I agree 100%, because I came from a more manual based clinic where a good amount of the patients, like if they had been there for a while, they were expecting manual work. And for me, I always question, like, what does manual look like? So for me, I prefer to do more of like palpation, or while you're doing it, some tactile cueing. So that for me is like, manual doesn't have to look a certain way. But for me, that's what I see hands-on approach as. But you're still moving, because I am not working harder for your plan of care and for you to get better than you should be. So I'm going to make you go through these exercises. And yes, it'll be scalable to make sure that you can do it. But I want you to know that you have to work in order to create lasting changes. And so that was hard for the buy-in in the beginning, because for so long people were used to, they'd come there, they'd get certain level of manual. I don't know the extent of each therapist's exercise, but then afterwards, if they put them through a couple of exercises, but for me, just straight for the most part, like you probably need to move more than anything. Your body just is craving movement, and that's all it is.
It comes back down to, like I said, like I put someone through a shoulder car. I'm like, how's that feel? Like, it feels really good. At the end of the day, movement's the biggest thing for people.
It was interesting. So I have someone right now that I'm treating coming to me for history of concussions. The beginning first week, I didn't give her any exercises, but just daily cars. And for me in my head, because I didn't know what her level of tolerance to any exercises would be, so I said for a week, or it was actually 2 weeks, didn't even give her any exercises but cars. She came to me, she said she feels better. But what I wanted to explain to her, because she had talked about the Epley maneuver and all those different types of vestibular rehabilitation. But I told her, when you take your neck through that full range of motion, one, it's causing like your muscles that you probably weren't using before as much to have to create some level of awareness and activation. And then on top of that, if you think of an Epley maneuver, or the barbecue roll that we learn for vestibular training, it's essentially doing the same thing as a neck car. So when I bring my head all the way back there, I'm stimulating different vestibular canals. So it's crazy for me when you start to look at, I don't need to isolate these things as here's a vestibular exercise, or here's one that's more for muscle training. I can do the same thing in just doing this whole system.
Right. Well, that's like, going back to like the hip, right? Oh, I need a glute med or a glute min or max exercise. And you're trying to think, you're sending them home with clamshells, this, and that for a glute. Like, well, let's just do something rotational. And they do a great job of saying, like, the stuff on this side of the joint needs to work more than this stuff. Like, you can get into like the nitty gritty with like the FR for manual therapy. Yes. But at least from a global perspective, I don't have to worry about the absolute specificity of this one muscle, like in the neck. Like, okay, global movement, then we can go from there. But no, you nailed that.
So I like that a lot more, because it made, especially being at a manual clinic, they're more specific. So like, this is this structure. And for me as a new grad, like that is cool to know as anatomy, but that doesn't help me clinically, because I'm just still taking in so much information. I'm trying to see what treatment style I like, what treatment style works best for the patients. But now I find it easier to just tell them, hey, this stuff on this side of the joint isn't doing its job, or it is. So now we can boil it down to, how do we now go from here? Just let's get this stuff to move better, and it probably will feel better.
Right. 100%. That's why I use a lot of, like, you guys ever go through the ISO ramping and everything? I know I
have done that.
So they touch on a little bit in like FRC, but they hit it hard in the ISM stuff. And that's been huge too. Teaching people, hey, this is where I want you to start working. And they're like, oh, I start getting, like you said, with the manual tactile feedback.
Yeah.
Yeah.
And so they used it for kin stretch. They have a video on it, and I think it's cool because they use it in two separate ways. So for those that don't know, so it's isometric ramping, and they used, I think, like a lacrosse ball or tennis ball. So they told us tennis ball because it's a bit softer for the beginning. But say if you're having low back pain or you want to work on specific structures, let's work on putting that tennis ball there, close your eyes, and then you're trying to find where on your body it is. So already you're now getting some level of a sensory input. Now let's get our maximum voluntary contraction with a mechanical part or motor part at where the tennis ball is. So now you're connecting the two of those, because in my mind, that's what manual should be, is how do I get you to sensory feel this to now improve a motor output? So right. I thought it was really cool because they'll use it before a class. So that way, hey, if I want to work the hips, let me put it on glute med or glute max or whatever it may be. And let's learn how to maximally contract that in a safe environment before we go and do all this work. Or I can do it afterwards, after I've now just worked it for an hour, and I can teach it how to ramp up, but then slowly relax to get me back in that parasympathetic.
100%. Absolutely.
So I really appreciated the ISO ramping. I haven't had the time to really do it too much, but I do it with myself. And it's been extremely helpful.
Yeah, once I was literally next to Dre, like he was going through some with their multifidi and their low back, like with back pain, which is what I treat 90% of the time. Unfortunately, like, oh, this makes sense. Like they don't even know how to actually use that. And I'm trying to get them to segment, which I don't know if you try to get someone to segment who has zero idea of their spine. It's tough. I mean, you're trying to find ways to like, there's some people that get it and some people like, all right, I got to come up with another solution here. But that was huge. And again, it comes back to you look at the scale of FRC and there's just, it is daunting at first. Like you look at that flow chart and you're like, where do I start? I mean, I've been through the information. I feel like hundreds of times you keep refining and refining and refining. But from a basic standpoint, if you taught someone cars as a clinician or as a patient, like there's already a huge benefit to that. And then you can kind of scale from there.
Exactly. And I like cars because we put it on our YouTube as just here's a free for morning routine. Here's how you do this. So for if I'm a patient now, I go through that and go, damn, that was hard. I didn't realize how hard it was to move this. So now it leaves you, and kind of like with the course that you take, that first day is, let me just show you how many joints on your body are fucked up. I'll tell you tomorrow how to fix it. But now for us, that gives people buy-in. So, okay, I can see this. This is great information and it's free. And it will keep you at the same level if you do it religiously. But if you want to make it better, now that's my buy-in for you to work with me as a one-on-one or come to my kin stretch classes or whatever it is.
That's a big misconception. People think cars make them better at their motion. It's a way to maintain, which is awesome. But then there's a whole another subset of things you got to do to gain more range of motion. Like you said, you show some cars and like, you're like, hey, can you rotate your knee? And they're like, what are you doing? Like you with the toes, right? You're like, what is that?
So I really appreciate it in that sense. One of the cool things about it though is I tell people this, and I hate using this example, but it's the best way I can explain it to people, because everyone goes, is it normal that it's like cracking and popping? I said, well, does it hurt? First thing, if it doesn't hurt, then I personally don't care. Right. But if it hurts, yes, let's talk about that. And the way I describe it is, have you ever tried to open a door that hasn't opened in years? And it probably makes that creaky noise. But what we're going to do is over time, we're going to pump in WD-40, so synovial fluid. So give the joint motion, give it rich nutrients. And now as you start to add more WD-40, the more you open and close that door, it doesn't make that creaky noise as much, but it's going to take some time. So that's usually how I describe it to people. So I like when they first say, I hear cracking and popping, because now I get the chance to use that analogy. And then people resonate with that way more. So I don't want them to think as their joints as an old creaky door, but
no, but I like that. I'm actually going to use that one, because like I get people doing neck cards like, oh, things are popping and clicking. I'm like, when's the last time that happened? Like, I don't know. Like, great, things are moving. Yeah. When's the last time you did this? No one's like, I don't know. Yeah.
And I love the other one is just like asking people. So they say, oh, it's really hard to move here, or I don't know why this is so difficult. And then my next question is, when is the last time that you moved it there? When's the last time your body was ever experiencing motion there? And then a lot of people will say, oh, like, I don't know. I don't usually do it every day. Then I give the splits example. So I'm like, can you do a split? They say, everyone laughs. He goes, of course, no, I can't do a split. I say, when's the last time you trained it? I said, oh, never. So why would you have it? And that is my explanation then for the other body parts. If you don't do it, why would you have it?
Right, your body's not going to keep it. Like everyone's like, "I want to go to put my coat on. This hurts." Like, how often are you reaching behind you? Like,
Yo.
Look, and coming from someone that used to do the split, I haven't done it since I was in grade school.
Oh boy, well now it's time to get back to it. Yeah.
I had a really traumatic story where I ripped my pants at school. Never happened again. Crazy. And so that's like in the 6th or 7th grade, and I was like, never been able to do the splits ever since. And it's like, yeah, like if you don't continue to do something, you
right
lose it.
Yeah.
Oh man. So that's a good one. That's a good at least excuse for not training it.
You should have seen my coach was like, you should have. And I was like walking to like the principal's office trying to hold my blue jean shorts together. You know what I mean? I split right in the middle. My wife tidies. I was like, oh well, I hope I wipe. I was like, I don't know what's going on.
That's a little traumatizing.
I was trying to show off in front of the, from the girls. I was like, you know what? I'm cool. Ain't nobody out here doing this.
I was clearly never heard this one before.
I never heard it to this level of detail. I knew he ripped his pants, but I didn't know it was that bad.
Traumatizing. But all that to say is that if you don't keep practicing something, you lose it.
Yeah.
You just proved it.
So
and sometimes you have to deep through some psychological things to get there.
Well, shit, then that leads to the next part. Then I asked him, well, you never trained the splits, and you tell me that elaborate story about how you ripped your pants. Now I know there might be some level of fear going into that range.
Oh yeah.
So
maybe we need to take it a little bit slowly.
Yeah.
yes, it changes it.
So segue then to segues into more questions, because if I go through something and I know nobody ever remembers or thinks it's relevant, even though I tell them, tell me your past medical history, because that will give me more of an inclination to go to a certain joint. If they probably injured it, they most likely do not know how to move it as efficiently as they can. But so then I look at it, and if the joint doesn't move that well, it's like, do you ever injure this? And then they go, oh, okay, yeah, I forgot I had a surgery here. Or I forgot that I hurt something here.
Yeah, that stuff comes up all the time. They're like, I'm like, oh, your hip. And like, oh yeah, I tore my labrum when I was like young. You're like, oh, that makes sense. Well, the therapy, like, they ever doing this stuff? Well, balance and stability, and that's it. And that's the best thing of like the way at least I treat it. It's one-on-one for sometimes 30 minutes to an hour, and they start slowly telling you stuff. You start learning more about the patient. That kind of then changes to where I'm going to go with them.
Yeah, 100%. And I like the fact that because so we at my old clinic, I'm now transitioning to doing more of my own thing. So I kind of dictate how long and the level of education, and that's my biggest thing that I always do for people is, if you see me 20 minutes, if you see me an hour, if you see me 2 hours, that's very minuscule in the grand scheme of your whole life. So what we do in that session, it could have some good benefit, but the biggest part is, what do you take away from it and how did you feel? Because if I give you a positive environment and I gave you a whole level of education, you're more likely to do that stuff outside of the clinic or outside of seeing me. So I really do appreciate how they teach you how to give a level of education to the person. So that makes them want to do it more often.
Yeah, if they understand what they're doing, then they're going to do it. Like, if you go through this whole session and then you're like, oh, hey, by the way, on the way out, like, do this car. And they're like,
yeah,
why? What does that mean? Like, they're not going to do it. But if you spend that half hour with them, going through it, teaching them, showing them the importance, the before and after, yeah, they're going to do it because they know. People are going to do things that are good for them for the most part, right?
But you would like to hope so.
Benefit, yeah, you hope so. Yeah.
So especially with the shoulder one. So the shoulder one, I know that they reach back at one point. It's like all the way back here. So when I first showed the people how to do it, they look at me and they're like, wow, that's interesting that hurts me to watch you do that. But then I show them, what do you do when you go to reach back in your car to go do something with your kids? It's like, that's that exact same motion. So now it paints a picture for them that, yes, this seems like an exercise that's really annoying or takes up time in my day. But if I don't train it, now when I want to use it, it doesn't feel as good as it can.
Right. You guys see like shoulder flexion, right? People start losing the ability to reach stuff on shelves or like grab their head. And well, now they're only able to do things in this plane of motion. And that really limits people as they get older. If they can't reach something, I mean, the less motion you have as you get older, we know it just really deteriorates your quality of life.
Yeah. And it's made me, this system has made me bite my tongue a lot, because everyone around me always gives the excuse, oh yeah, like that's how I know I'm getting older. No, probably that's not the case. Yes, you're probably getting some aging like limitations, but most likely, if I had to guess, you probably just haven't moved it.
Right. Oh, I had a patient today tell me, wait till you turn 30. I go, 30? I'm like, oh, hold on a second. No.
Yep.
That's not what it should be. Yeah,
but the other funny thing is I had a patient come in and she told me that she hurt her back going to pick up, I think it was a piece of paper. And it shows like if you don't use this stuff, a piece of paper will end you. Like it could be that minuscule because your body's taking insult after insult. And if you don't give it the love and care and attention that it needs, now it's going to tell you later on when you want to do the things that you usually do. You haven't been giving me some TLC.
Oh yeah, the amount of times I hear that in the clinic of like they hurt their back on like the most silly thing. I picked up a pillow or I just reached down and like
yep.
The day before they're in the gym deadlifting hundreds of pounds, but then they go, I was the deadlifting guy. It's like, no, it's the fact that you don't use your back outside of that one thing you do a week.
Yeah.
Right. Like, even though you go to the gym, you are active, CrossFit, whatever you do, but if those are the only thing, like you're only going to be good at deadlifting. Like,
right.
You won't be good at other motion. So now you're picking over, like you're bending over with like a slight twist in your body.
Yep, that 1 degree.
That your body doesn't know how to control that motion. It's not going to be able to during that during that activity. So it increases that chance of getting hurt.
Exactly. And that's why like card surgery, right? We're using that entire range of motion you have in that shoulder, not just doing this all day or this just all day. You're really good at that, but then you ask people to go ahead and rotate. You have people just do this. They're like, what are you doing? I've never done that.
Yep. We now so when I first had my student his first week, I told him to watch the morning cars routine because I told him I don't care how you treat, but that's just what I'm going to tell you that I want you to give people for homework. So how you get that stuff to look better, I don't care, but I want you at least to have this because from what I've learned over the last couple of years, this for me makes the most sense on how to maintain longevity of a joint, which we all are going to need going forward, because that's why there's so many people that come in with total knees, total hips. They get spine fusion because we have so many joint issues, but we don't treat the joint. So for me, I told him that's the main staple on how I treat. So try to learn this. And then he would come to me after we did like hip rotation and he'd say, okay, but what about if you did clamshells? So yes, clamshells might be great for everyone, but then notice at a certain point that exercise has its limitation. It only goes from this window to this window. Most people probably need strength in that window, but now you got to train them outside of that, because if they only get good at doing sideline clamshells, they're only going to be good at doing that. But now we got to touch upon other things. So it's a nice way of looking at the whole system and say, in this entire range of motion, where can you move from? Where can you not? How do we strengthen it? So there's nothing to say I can't get hip cars better by doing clamshells. So there's no right or wrong. It's just parts of it that I want to. As long as you have an intent to the exercise, there's no right or wrong answer.
Right, because like you look at sports, right? It's a chaotic environment. It's never the same thing over and over and over. You get a soccer athlete and they're constantly changing direction, different every single time. Well, if that hip can't handle every single force vector in that joint, well, we're going to blow through something at some point. But if you did clamshells, you only got good at that line of tissue, that range of motion, which if you're just someone who's only moving that all day long, awesome. But like we said, Patrick, like the deadlift, right? If you did this movement with a little bit of rotation, well, that tissue's never seen that before, and boom, there it goes.
Yeah. So I give people, because we're out in California, I give people this example of, I give you two menus, and I can give you an in and out menu or / Raising Cane's menu, where it's got 3-4 things on the menu. That's all you got. Or I can give you the Cheesecake Factory, where that's a booklet. That's just, you get endless options of that. So I want to take you from an in and out menu or Raising Cane's menu to a Cheesecake Factory menu. So now, God forbid you want to eat healthier, we got this option. If you want to eat more of the cheesecake, we got this option. So now that takes you through all of your different daily activities. I don't want you to only stress the same lines of tissue, because after a while it's going to break down. Right. Now I want, or get quote unquote bone on bone. I want to give you as many options as possible so we can disperse the force and then decrease the amount of the force that goes through a specific tissue.
I love that. And I think it's good, like, to explain to patients sometimes it does seem a little daunting. Like maybe are we overeducating on some things, but they need to know this stuff. Because if you just don't tell them that and like don't explain lines of tension, tissue, I mean, they're not stupid. They can learn this stuff if they're taught right and over you teach them that. But just to say they walk in, you go, yeah, you got a bad knee. Yep. It's arthritic, and then they just feel lost.
Yeah.
So it's like, I think that system gives you
limit everything that they do. I was like, oh, I got a bad knee. I shouldn't do this.
Yeah.
You should probably move.
Yeah.
As much as you can, in which your body allows you to.
Right. Everyone comes in. I got a bad shoulder. This is my bad knee, and that's my bad knee.
I hate when people say that because they don't know the level of power that their words carry. Because now they're giving themselves kind of fear-mongering words because they say, oh, I have a bad back. What does a bad back mean? And probably, did you try everything possible to make this back move as best as it can? And if you didn't, let's try that first before we say we have a bad back. Because I guarantee if we try to be more specific in our treatments, you'll probably have a better back. And now your subconscious doesn't know the difference between me just saying it as a joke and then me actually thinking I have a bad back.
Right. And that's partially the faults of our fields too, right? Like you have people that they failed PT or they went to a chiropractor for 6 months, they still have this pain, and they go, well, it is who I am. Like this is identify as I have a bad back. They don't realize that that's not a life sentence. There's very few people that have a life sentence of bad backs, like completely traumatic incidents that had to have completely like just because you picked up a pillow wrong 6 years ago doesn't mean now you have a bad back the rest of your life. Just like teeth, right? Like the dentist thing. Just because you had a cavity doesn't mean you're always gonna walk around and say, I got a bad tooth. That's it. Like,
I like that one. Now I can add that. I can add that one to my analogy.
There we go.
So I agree 100% with a lot of that. And we try, I think the level of education, and that's how I start to, I don't want to say weed out, but that's how I can start to pinpoint who I know will seek the most amount of benefit from the way that I treat. Because if you don't like that level of education and you just want to get manipulated, or you just want to have some soft tissue work done on you, I don't want to work with you in that sense. I want people that want to be open to learning, because what I'm teaching you at this point is how to be a better human. So our body tells us that we like movement by sending like endocannabinoids and all the endorphins when we work out. So people feel great after they work out, and that's your body signaling, hey, do this more. I like this. Keep doing this. Yeah. So they get runner's high. They get after they go to like their spin class, they feel amazing. They feel a good energy connection with other people. And that's what we're supposed to do, is be able to move and then connect with other people while we move. So if you don't find joy in that, then I don't think we're going to be a good match. So I think the level of education is great. And then if they take it, perfect, then we can work together. But if not, then we might not be the best fit.
Right. And it's good you recognize that too. Like we have some providers we recommend to or refer to. We're like, this person just wants, a passive modallion. Great. I can't change them because you can't force somebody to do something they don't want to. Again, it's their values.
Yeah.
I'm glad that you guys also see that and recognize that. That's awesome.
Yeah. And I think it comes down to, what we even talked about in school for us in terms of like research, like give people all the information possible so they can make an ethical decision on whether or not this is right for them. So if I give you the information it's not right for you, I don't want to keep you from reaching whatever goal that you have.
I like that too. Like with FRC, it's backed by research. People always ask, like, can you send me this? I'm like, it's all there. And that's what I really enjoy about the system. They're not just making stuff up. Like there's that you look at Michael Chivers and Stratorius, or whatever. I forget his last name, but they'll show you every single paper ever imaginable on joint pain or joint dysfunction, whatever you want to call it. So it's not like we're just making this stuff up. And I'll send some stuff to some patients. I keep some stuff in my career, like, here, read through this. Like if you want to know more, like it's there. Like, some people take it, some people won't, but at least it's there.
Yeah. And the other thing that's been really easy of describing this to my friend who's learning, he's in his last clinical, about to go, and he's had some crazy good successes. So I liked how he's had his thought process, but I told him this is no different than the traditional stuff that you would have done, but now it breaks it down in a very simple fashion. So first, isometrically, can you just produce force here? There's no movement happening because this is the lowest level of stimulus for your central nervous system. Once we now gain that, or even at some function, we start to gain more control there. Now, can we hold it isometrically? Now, can you concentrically do this? Now, can you eccentrically do this? And now, can you draw circles in a certain range? So we're ramping up different parts of your central nervous system. But it all comes back down to the regular strength and conditioning that we learned, because you want to start someone off slow. I'm not going to put you on 225 the bench press if it's your first day in the gym. I'm going to teach you how to do this first, and then slowly build you up in various ways and different accessory lifts. So that's what I like about the system, and like about how it's helped my thought process. So let's just slow things down. Let's simplify it. Can you first do the very basic level? If you can't, let's start there. If you can, now I can progress you a little bit more.
Right. And that was the nice thing. Like, it gave me, there's a system to follow, because I'll remember like my first experience in the clinic, guy comes in with knee pain, and I'm like, I did all my orthos, I pushed on it. Okay, here's where it hurts. And then the teacher's like, okay, you're going to adjust the knee and then go grab the laser. I was like, well, what does that even mean? Like, what are we treating? There's no real diagnosis. There's no like, here's the objective findings. It hurts on this, and there you go. Hopefully it doesn't hurt later.
Mm-hmm.
At least, like you said, with FRC, you have a progression system on where to, and everyone starts somewhere, but at least you have that sliding scale of, okay, someone might be starting here, someone might be starting here, but at least there's a path to follow. And that was what I loved. Like, the first thing I saw, I'm like, this just makes sense.
Yep. And for me, I always stay away from diagnosing. So kind of what you're saying on that sliding scale is, I can show you, all right, this is what I expect. If you can't do it, now I know that probably we should probably get these areas to move more efficiently. So if I look at like someone with knee pain, for me personally, I always start down by the toes and feet, because that's the easiest way for me to cue. And then I try to see how well do you take my cues. If I need to give more tactile cueing, then I know that when I give you stuff later on in the body that's more complicated, I need to be more specific and help you a bit with some of the cueing. But then if they're coming in with knee pain, low specificity, should I check their knee? I probably should check, how does their knee move? So now it gives me a starting point. And then those other things, if they move well, then I don't need to worry about them. But if they also don't move well, then it's another area that's probably contributing. So if their hip has bad rotation, I can definitely help them out with some hip rotation, but also still check their knee.
Right, because everyone's always asking, like, what's the diagnosis? Do I have a hip impingement? Do I have an MCL tear? Do I have a meniscus tear? You're like, I'm not going to say any of that stuff. You just have a hip that doesn't move, and you know, whether it's active, passive, you have a knee that doesn't rotate, and you have an ankle that doesn't dorsiflex. Like, they go, okay, well, that makes sense. And it's not like a life or death thing, right? Like a meniscus tear, people, that's a scary thing, because they know it's a surgery. I can't do things I want to do anymore. But if you tell them, hey, you need more control on your hip, they go, okay, well, I can do that. Like, it completely de-escalates them. They're not walking out there thinking like, oh, I have a herniated disc in my back. You're like, oh, I just have a back that doesn't move well. Awesome, we can fix that.
And that's the best part is I feel like with a label or a diagnosis, it's all right, I have this, but it doesn't tell you anything going forward. So I told him also in the beginning, I don't do any special tests, because the special test just told me that if I do like the Hawkins Kennedy, so if I bring someone's arm up and do that, it hurts and pinches. Okay, so what does that mean for me? But instead, what do you have? What do you need to do? Or what are you trying to do? And what can you not do of that? So let's just make this simple and say, move the things that are supposed to move in that range. And that helps me way more than saying you have a positive knee or test or positive cam and pincer or whatever it is. So it gives me more for them to look and say, these are things that are easily attainable if I put in the work.
Go ahead, Patrick.
Once you start like labeling meniscus tear, things like that, I feel patients lose or maybe not aware that those things heal. Like if you have like a meniscus tear,
right,
it can heal after a back strain. I was like, oh, my back went out. I was like, you know, that heals in like 6 weeks.
Right, yeah, natural history, right? Like,
right, natural healing time. Like, so now it's 5 or 6 years later, and I was like, yeah, I have a blown out back. Like, no, you just don't move well. Like, you stop moving. Yeah, so you stop moving after your injury because you thought this is a lifelong thing. No, that was like a short thing. Now you just don't move because you were afraid to make it worse.
Right, people come in like, oh, I have bulging discs. I'm like, when did you have that? They're like, oh, I had an MRI like 10 years ago. It's like, well, I mean, would you still have them? Sure, but have you had back pain for the last 10 years straight? Like, well, no. I'm like, well, okay, but they do. I mean, that's why I'm always hesitant to give out a diagnosis, because people they'll run with that.
Yep, and they use it. Use it as a scapegoat. I had a woman, I think when I first started, where she was relieved that she got a diagnosis because she said, now I have something I can blame it to. but she didn't want to do exercises to address it. So whenever, say, her knee started bothering her, exactly. So now when her knee started bothering her, she said, oh, I just have patellar tendonitis. Like, yeah, but do you know what patellar tendonitis means? And I liked the explanation they gave of injury, or, and more so injury, they call it, is the mathematical equation. The load that's going into this tissue, can your body handle it? If it can, then okay, you probably don't have most likely the injury. But if you can't handle it, then that tells you that's probably where you should start. Let's increase the load bearing capacity of this tissue or this segment, and it will probably feel better.
Yeah, 100%.
So that's the one that I was describing with jumping athletes with like knee pain. A lot of them have patellar tendonitis and think that it's normal just because of jumping. Well, no, we got to increase the capacity with which that you move.
Oh, everyone's got a tendonitis, right? Like, it just is what it is. I have elbow tendonitis. I'm gonna have it forever. It's like, well, not necessarily. Yeah,
yep. Doesn't have to be that way.
No, yeah. I have so many kids come with like Osgood Slaughters or like tendonitis, and then like, when did you get diagnosed that? Like 6 years ago. Well, the odds that still Osgood Slaughters is probably pretty minimal. I'm like, did you have imaging done? No, they looked at it and said that's what it is.
Yep.
Oh, and like you can probably change that fairly fast.
Yeah.
Really the right inputs, right?
Yep, of course. So kind of want to close things up a little bit, but I do want to have if you can kind of drop some of your social media information, because I know you've got a really good selection of content that you post on your Instagram. So where can people reach you at?
At drkyle.richmond on Instagram. I haven't really done much else. I was on TikTok for a little bit, YouTube, but mainly just Instagram right now. I've been trying to post something pretty much daily. Just quick stuff, just educate people. Again, it's not meant to cure anything, but just raise awareness hey, do I have a knee that moves or a shoulder that moves well, and kind of give them some insight, at least start the conversation. I try to take all the stuff I've learned from FRC to ISM and just slowly start to teach people that. But yeah, I'm just big on Instagram right now.
Nice. Pat, got anything?
I do have a question for you. So more so, what type of things do you like to learn? So I know FRC's been pretty big for you. And is there anything else that you're looking into?
So FRC's taken me like I've done FRC, FRA, going into the soft tissue work, ISM. It's kept me super, super busy. I did do a lot of McKenzie stuff. I know there's a few more courses I could take. And that's what I'm kind of looking at. What's like the next thing I kind of want to learn, but now using my lens of, okay, I understand all these principles from FRC. What can kind of be the next course that I can take into? Like I've done, like, you guys know, like DNS, dynamic. Like, again, I use some of those things when you look at like the full scope of what you know. Okay, there's a place for it. But actually, Patrick, I'm trying to see like what would be the next thing to kind of dive into. ISM blew my mind. I'm still like going through all that stuff. But again, I don't ever want to be the person that stops learning. I've only been out of school for a year and a half. I just said FRC is my only thing ever, or FRS. Like, that's ignorant for me to say. There's going to be other things I should dabble in. I don't know necessarily yet, but I definitely, I'll go through a lot of their stuff they talk about, like the books. John Quinton, Dr. Chivers do a really good job putting out like the whole chaos theory stuff, dynamic systems theory. So I'll try to learn stuff like that and how it applies back to FRC, if that makes sense. Like a lot of those books. Well, that's about it right now. But hey, if you got any recommendations, Patrick.
Not so. So right now, I'm more in a space where I'm learning more about relationships, building communities, and so that way I can know about myself, learning more about, all right, this is how I navigate through the world, some of my triggers, some of my boundaries, and so now I can, when I step into like the clinic, those are some of the questions that I'm asking my patients. Like, all right, I want to touch your shoulder here to show you this movement. Like, can I do that? Because I know everybody has a different response to manual cues. Like, I was Tyler's big into tapping when he's like doing manual, and I physically hate that. Like, nothing irritates me more than someone tapping on me. And so like now I'm more aware of that. Now it's like I can ask people what things that you don't like. So as we're trying to customize the session for you, like I want you to get the most out of it.
I like that, because that's something, again, in the whole therapy world, like, or manual therapy, it is a therapy session for these people. Like we're with them for 30 minutes to an hour, you know, face to face. Like it's just you and them in a room. Like you have to understand that stuff. That's something definitely I haven't definitely gone into enough. But I mean, it's therapeutic for people. You got to learn. There's a human being in front of you, right? Pain's one thing, but how to talk to them and how to put it, you know, into their perspective is huge. So you gotta send me some of the stuff you're going through.
Look, I got you.
All right, I love it.
What's a book that you're reading on relationships now?
So right now, All About Love by Bell Hooks.
Okay.
So right now in the book is self-love. And so it's a lot of it is like, what are you doing with your time? And so with self-love, like, are you working in a job or committing time to things that drain you or like give you energy? Because we just trying to put ourselves in positions to do the things that we love more, to have a better outlook on our life.
I like that a lot. I'm gonna have to read that.
Yeah, so that's the space I'm in this book. And so just trying to continue that. So like with the things that I'm teaching patients at the end of the day, like I want to have a good day. Like I want to be at work. I want to be excited about getting people better. So how do I do that? All right, let me express myself in these ways. And so if I want to be more educational today, all right, let me do that.
Right.
And so I'm looking at it through that type of lens.
Oh, I get that. You look at your schedule some days. I'm like, I have like 5 pages on my schedule. Like they're full of energy. Like we have a great time. Like you get home from work, you're like, I feel good. And then you have your other days where you're mentally drained, and you're like, I shouldn't be like that for work from that many hours. You can't just do that over and over. So you have to take a look at yourself too.
Right. Yeah, exactly. And so, and then some days like you really can't help it. It's like people just need more energy, and you just have to put that forth. And but
hey, you put that game face on, right?
Yeah. So it's like, you know, but trying to find those things where you can now take control of your life and be responsible for your life.
I love it. Yeah, you have to send me that book. I'll definitely take a look at that.
Gotcha.
Dope. I like that. But yeah, appreciate you for coming on, spending some time sharing your thought process, some good conversation. Definitely, yes. I want people to check out your social media. I forgot exactly how I got in contact with you, but I remember seeing your stuff, and I've taken some of the exercise that you've done and just implemented it into my own practice. So it's a good network to have. Yeah.
I don't even know how I follow people. I just remember when I started, like anyone that had FRC like in their tag, I'm like follow, because again, I'll see something you do. I'm like, oh, that's genius. Like I'll do it. Like I have no problem with people stealing what I do. Like I don't own it. Like if you see something's awesome for a hip, go for it. No problem.
And that's what I love. Hopefully to continue to grow that kind of a community of here's just what I did that works. Maybe it'll work for you, because everybody needs something slightly different, where generally the process is, if I need to get you more hip rotation, I need to get it to you, but there's different ways in which in which you will be receptive to. So being able to see a bunch of people just have their absolutely brilliant just ways of doing different exercises, I think is cool. So continuing to grow that community would be pretty fun.
I try to be careful, like the whole, like, oh, you got elbow pain, try this. Like,
yeah.
I definitely do some clickbaity stuff. Just, I mean,
you got to. Sometimes you have to.
But I definitely try to put the disclaimer, like, hey, if this hurts you or this, like, don't do that. Please don't do it.
But all right, thank you again, and we'll kind of cut it here. We definitely have to do a part 2. So,
absolutely, anytime, guys. I really appreciate you having me.
Of course.